Excellent. Well, I'm really excited to be here this evening to talk to you on this topic. I think it's a really important topic, and I'm excited that more people want to learn more about it. It's something that, unfortunately, as fitness professionals, we don't always learn a lot about. So this evening, we'll be talking more about the pelvic floor, get an understanding of it, and how you can perhaps start to coach it a little bit differently in your own sessions. My name is Brett Best. I'm a certified personal trainer. I'm also a holistic core restore coach. I'm not a pelvic health physio. Holistic Core Restore is a program that was made by pelvic health physios, and then fitness professionals can take some training and become licensed to deliver that program. So some of the clients I work with come to me specifically because they are working with some pelvic floor challenges and they're wanting to know how best to get back into exercise or continue the exercise that they love doing. I got into this because I clearly am interested in it. I have my own pelvic floor struggles. About November 2022, I got a bad case of pneumonia and I had a hard, heavy cough, and I coughed for 7 weeks straight. And at the end of that, I was going up the stairs in my house and it felt like something was falling out of me. And I thought, oh dear, what's this? And I went to the GP who said, yep, you've got some prolapse. I'll refer you to a gynecologist. And on the NHS, that took 11 months. And that 11-month journey, it is what brought me here today. Because in that 11 months, I was that woman in the group fitness class who knew that maybe I could do some of the movements, but perhaps I shouldn't, because all of a sudden the things I used to do were causing symptoms. I didn't know how to regress. I didn't know how to change. And I didn't think that the people who were writing the programming and the classes would be able to help me, because they were, I mean, I was a personal trainer. I didn't know what to do. They never talked about pelvic floor. I didn't think they knew what to do. So I was feeling very lost, very confused, and I took every CPD and certification I could find about pelvic floor and pelvic floor fitness professionals, and I'm here to share a lot of that information with you here today. We'll jump into it. I'll be giving you a lot of information. These slides will be available. This recording will be available. Watch it back as you need to. We'll kind of be zooming in and out. We'll zoom in on the pelvic floor itself. And then I was really excited to see in the circle group that there was an interest in how the pelvic floor was connected on a bigger scale to the whole body. So we'll kind of zoom out in that way too. We'll sort of be zooming in and out as we go through this evening. So we'll talk about the pelvic floor. We'll demystify it a bit, understand what it does and how it does connect to the whole body. We'll talk about some common pelvic floor dysfunctions and how those might show up in an exercise environment. We'll talk about coaching strategies that you can start to use, things to look for, know your scope so you can offer options, but also know when to refer out. And at the end of this, hopefully you'll feel a little bit more confident to offer people in your class some pelvic floor modifications. This is an important topic because 1 in 3 women experience some kind of pelvic floor dysfunction. If you think about a group exercise class, if you have 15 people in that class, potentially 5 of them have some kind of pelvic floor consideration they're working with. Pelvic floor issues affect almost half of the menopausal population, that's perimenopause and beyond. And that's because estrogen is really important for the integrity of our connective tissues. And so as we start to look at the pelvic floor as sort of like this hammock or trampoline that sits in the pelvis, as those connective tissues start to lose elasticity, we can start to lose some pelvic floor function. It's not just a women's issue, however. I think it's important that the men in our class realize that this applies to them too. And there's a high correlation between pelvic floor dysfunction and low back pain. And that's because the pelvic floor is integral to maintaining pelvic stability. And if something's a little bit off, then other tissues and muscles in that area can kind of become tense as well and sort of start to take up the slack. Symptoms are really common, even in fit and active clients, but not often talked about. And you can definitely make a difference as part of the solution, which is movement. Movement is definitely a part of the solution. And if we're helping people with movement, we can definitely help them with that solution. As I mentioned, it's not just a women's issue. Men may experience incontinence, especially after prostate surgery. Pelvic floor dysfunction contributes to erectile dysfunction. And as we mentioned, there's also correlations with low back pain. I've had a male client who had diastasis recti. So it's important that as we begin to talk about pelvic floor and exercise, that the men in our classes know this applies to them as well. And I think that's a really important point to make, is that we perhaps should talk about this very openly. Just as we would talk about the shoulders or the glutes, I think we should also talk about this muscle group, the pelvic floor. The more you talk about it, the more you normalize it, the more others will feel comfortable approaching you with it. So you can screen so that you know. My own physical activity readiness questionnaire, my own PARQ, does have a question. Do you experience leaking, heaviness, dragging, bulging sensations with exercise? And like all of those questions, if there's a yes, you'd follow it for more information. If you wanted to do a deep dive into pelvic floor screening, the Continence Foundation of Australia has some amazing resources, and they've got a screening tool you could look at. But just in this way, we kind of have it on our radar who may need a little bit more modifications or options, and create that safe space for people to come tell you and talk to you about anything they may be experiencing. We'll talk a little bit more as we go about knowing when to refer out and encouraging people to see a pelvic health physio. And viewing that not as a handoff, but really as a next step so that you can work with that pelvic health physio to understand what's best for them. So just a quick view of the pelvic floor. We're looking down on the pelvic floor here. What we don't see here are any of the connecting tissues, any of the muscles that go into the hips, the glutes, into the torso, any of the innervations. This is really a zoom in on the pelvic floor. And the pelvic floor is like this hammock, this trampoline, and it supports our different organs. It's important for continence, both urinary and fecal continence, sexual function, blood and lymph return, and it doesn't act in isolation. It very much is responsive to the body. It moves with the body, responds to pressure and load. You can look at that a little bit more. This is a nice video. I think we're short on time, but we might watch a little bit of it if we'll play. Let's see. I like this video for a couple reasons.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, they leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to twist and draw in the muscles around your vagina as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks.
So I like that video for a few reasons. It shows you how it moves and what's exactly happening. But it's also made by the Continence Foundation of Australia, and they are a great place to look for more resources. I already mentioned they have a screening tool. They also did a pelvic floor first campaign about a decade ago, and a lot of the information for fitness professionals, and a lot of the information that they put in there still holds true even with current research. So it's an interesting resource to check out. And we're going to draw on some of the things they said about pelvic floor activations in just a moment. I want to quickly zoom out now and look at pelvic floor dysfunction, because a lot of times we think it's about weakness. And so maybe we think the answer is just to do more Kegels. We'll talk about Kegels in a moment. But there's actually a lot that could be going on. So it may be that the muscles have low tone, which often kind of rides with weakness, so they can't really make a good contraction. But it also may be that they have too high of a resting tone. So just for the purposes of this evening, we'll say they're too tight. And that can also be problematic, and they can also be weak. And that's because they can't actually get a full contraction. So if you think about your bicep muscle, if you just extend your arm and flex your bicep, a tight pelvic floor would be like a bicep here, and it's only able to go this far. So it can't fully extend and contract back. So it's really holding a lot of tension. Instead of opening up and coming back to a contraction, it's always kind of here. And that can cause just as many problems as a weak pelvic floor can. You'll still get leaking, potentially prolapse, and some other issues with a tight pelvic floor, just as you would with a weak pelvic floor. There could also be coordination and timing issues, so the pelvic floor might not be working in sync with other parts of the deep core, which we'll look at it in a moment, and some of the surrounding musculature. There may be an asymmetry of muscle imbalances, so that if these muscles are imbalanced, there might be more load and pressure put through the pelvic floor, or the pelvic floor has to stabilize more than it normally would have to. So there's a lot that can go on to create a lot of these dysfunctions, and people can have more than one of these things happening at the same time. It's quite hard to know what's going on if you are coaching a group fitness class, so this is one of the good reasons to refer someone to a pelvic floor physio. Here's how it may show up. Many of these things you probably have already seen, and you probably already would have guessed. So we have stress incontinence, which is leak with impacts, urge incontinence, needing to go, like just in case, like right before you start your exercise. Many times, very intense, high intensity work can cause urge incontinence sort of mid workout as well. Prolapse symptoms, so heaviness, dragging, pressure. Diastasis recti, which would be the doming that you see. Sometimes in the tummy, you'll see a little bit of doming happening. We'll talk in a moment about why that happens. And even people who are very strong may have some leaking because perhaps they have a bit of a tight pelvic floor. Sometimes you'll see people holding tension in other areas as well. Or perhaps those pelvic floor muscles are just a little bit deconditioned and untrained. There's lots of contributing factors to all of this, and many times there's more than one. Some of them are listed here. I think of note are things we don't always think about, like time of day. So pelvic floor muscles are like any other muscles. They tend to be strongest in the morning, and after they have to stabilize all day, they can be weaker in the afternoon or evening, which is something interesting to think about if you run an evening class. They can also be susceptible to cumulative load, so it might not be one workout or one exercise that has been too much for the pelvic floor, but it might be someone has started to do a lot of exercise and they've really ramped it up. And maybe that cumulative load over the past couple weeks has just been more than the pelvic floor was able to adapt to. Things like stress can also impact the pelvic floor via the nervous system if you're holding a lot of tension, illness, muscle imbalances, posture, breathing, even foot health. So let's get into some of these a little bit more. What helps the pelvic floor? Well, exactly what we do. Total body strength training, especially breath work and deep core reactivation, which you might not have a lot of scope to do within a group fitness environment, but we'll kind of talk about some things so you have them in the back of your mind and they're on your radar. Anything that works the glutes, the lateral hips, and the adductors, so the inner thigh, is going to potentially be good for the pelvic floor. Postural awareness, we'll talk in a moment about why that's important for pelvic floor, and gradual load progression. The pelvic floor is responsive. It works with the body. So many times as people start to get stronger, the pelvic floor will start to get stronger as well. I have several clients who will say, you know, I used to leak, or I used to have to plan my journey around bathroom stops. And since I've started exercising, I don't have to worry about that anymore. It just sort of happened naturally that way. So that's where we come in. This is where we're going to zoom out a little bit. And I know I'm going through this very fast, but I've got a lot to cover. We'll look at how the pelvic floor is connected to other surrounding parts of the body. This is the core canister. It's a core concept, no pun intended. And this is the deep core. The deep core is made up of the pelvic floor here at the bottom, the diaphragm at the top, the transverse abdominis, which is sort of like a corset. It runs here in the middle, and the multifidus. These are spinal stabilizers. And this deep core works together to create this intra-abdominal pressure that helps to stabilize the pelvis and the spine. And when that pressure canister is working the way we want it to, then there's not a lot of downward pressure on the pelvic floor with movement, lifting, or different activity. Here we can start to see how things like, for example, breathing might affect the pelvic floor. If you take your hands and place the hands on the side of your ribs and your thumbs on your back, take a deep breath in through the nose. What we want to feel happening is everything expanding and the belly going out. So it's almost like there's a balloon behind the belly button, pushing the belly forward. And it's almost like an umbrella is opening here underneath the ribs. And that allows the diaphragm and the pelvic floor muscles to work in conjunction. As you inhale, everything goes down. As you exhale, everything sort of moves up. And when we have these breathing patterns, the nice big is called a 360 breath. It allows that intra-abdominal pressure and that movement to happen. Many times what you start to see is maybe people breathe in, and instead of the belly expanding, it actually goes in, or you'll see a lot coming up into the chest rather than a 360 breath. And that then means that the diaphragm cannot expand fully, which means pelvic floor mobility may start to fall off, and it just starts to impact pressure dynamics. So little things like just how you breathe become very important. We start to look at posture. If you think about kind of sitting all the time like this, it can make this stuff very tight. And then you're sort of also pulling that canister out of alignment, or pelvic positioning. So anterior, posterior, pelvic tilts kind of throw that core canister off balance, which can potentially start to impact intra-abdominal pressure and pressure down on the pelvic floor. Now, we don't have to get pedantic about movements and posture and alignment, but it's just interesting to know that all of these things do affect each other and potentially impact the pelvic floor. This is how the pelvic floor is part of a bigger system, and it's not working in isolation. This actually leads to, I think, your strongest coaching cue, which is exhale on exertion, blow out on the hard part. And this is the reason why, because if you think about, as we inhale, that diaphragm and that pelvic floor go down. As you're exhaling, it's all kind of coming up anyway. So if we're exhaling when we do the hard part, we're less likely to bear down on the pelvic floor. So it's just moving in a way that helps to support that pelvic floor. This is an interesting diagram from the Continence Foundation of Australia, which shows this. When you're breathing easily and you're continuing that breath, you have the intra-abdominal pressure maintained throughout. And if you're exhaling, if you're holding your breath, rather, if you're holding your breath, there may be more of a tendency for that pressure to go down, or in the case of diastasis recti, maybe to go out. So that exhale on exertion just kind of helps to work with that pelvic floor. Interestingly, you'll see on this diagram, it also talks about engaging the pelvic floor and pulling it up. So that's something else we can look at. It's kind of hard to talk about pelvic floor and not talk about Kegels. So what is a Kegel? It's kind of what that video is showing us with the muscles contracting. There's a lot of misunderstanding around Kegels, though, and you won't be using Kegels in your group fitness class, but I think this is interesting to have an understanding around and talk about. Kegels are often described as stopping the flow of urine. Please don't actually do that. But that's really just sort of activating the anterior pelvic floor muscles. There's also a posterior pelvic floor, and so that would be stopping the passage of wind. The great way to do Kegels is actually from the back passage up, And it's not just a squeeze, it's also a lift. So cues that are often used for this are, imagine you're sucking up a marble. Imagine you're sucking up a blueberry smoothie. So it's not just a squeeze, like a stopping the flow of gas or urine, it's actually a pull up. For men, it's often cued as nuts to guts, or imagine your testicles on a cold plate. So it's a up. Really important for you to take away now, though, is that these Kegels can be done in different positions because they can be easier to feel in different positions. The easiest place to feel a pelvic floor activation is laying down with your knees bent, maybe even with the hips elevated. So with a pillow under the hips, gravity kind of helps. You're going to probably feel your pelvic floor activations better there. Then maybe moving into a quadruped, so all fours position. Then from there, maybe seated and then standing. That's important for you to know as a fitness professional, because if somebody doesn't have very strong pelvic floor muscles and they're standing, they already may have trouble engaging their pelvic floor. So just to kind of keep in mind, different positions are potentially going to be easier for people to feel those pelvic floor activations. Kegels are done to build strength and awareness. The Squeezy app is very popular. It helps you follow along and build the slow Kegels, which are slow twitch muscle fibers, as well as the faster Kegels, which are the fast twitch muscle fibers, which is what you're going to use to help you when you're coughing or sneezing or needing to activate correctly. But, Kegels aren't for everybody. If somebody has a tight pelvic floor, the last thing they may need is Kegels, because they're just doing more of this. They may actually need more down training and learning how to let go. And that's a completely different thing. So Kegels aren't for everyone. Very interestingly, research shows, and there's a lot of research showing this, that up to 50% of people perform them incorrectly, even with instruction. And this is a great reason why people should see a pelvic health physio, because they can do internal examinations and tell you if you're doing it right. Very often people think they're activating their pelvic floor, they may actually be bearing down. Or maybe they just have a squeeze, but they don't have the lift. So it's important to keep in mind that a lot of people don't do them right. And I just want us to be aware of that, because in the fitness world, we often hear, and this is in the pelvic floor world in general, you hear a lot about the knack. The knack is a reflexive style Kegel, which is done just before a movement of increased pressure. So like coughing or sneezing. So if I had known about the knack so many years ago when I had pneumonia, would I be here now? Who knows? I don't know. But it's a reflexive kind of pelvic floor protective response. It's not done for reps or sets or as an exercise. It's just engaging the pelvic floor to prevent that downward pressure. And that's what that graphic from Continence Foundation of Australia was referring to. This can be really useful for heavy lifting, and we'll look at that in a minute. However, a lot of people don't know what's happening at their pelvic floor. They, it's just an invisible, rarely taught muscle group. Those innervation pathways are not well trodden. They're not sure what's happening. This is especially true for those who might have a tight pelvic floor, and they may do a lot of other things instead of activate their pelvic floor. So we want to talk about pelvic floor in a fitness environment, but perhaps we want to be a little bit mindful of cueing pelvic floor activations, because we don't actually know if anybody's doing it right. Let's zoom out again. We're going to come back to that in a moment, but let's zoom out again and look at how the pelvic floor is part of the whole. It's part of an integrated system. We've already seen how it's an important part of the deep core and the core canister, and how it helps to regulate that intra-abdominal pressure, how it responds to breath and posture and maybe even emotional states. It's also quite often the case that a deconditioned body will have a deconditioned pelvic floor, because the pelvic floor is so responsive. Somebody who's just generally unfit may have some pelvic floor dysfunction, because if they're not moving or really challenging their body, then the whole system, the pelvic floor included, isn't really being challenged either. It's also important to think about people who may be coming to group fitness classes and who are just getting back into fitness, because it may be the case that certain muscles, which should help with stabilization, aren't strong enough to do that yet, and there might be more pressure through the pelvic floor to help stabilize. As you get somebody moving, very often pelvic floor will get stronger along with them. But people who are very strong and very active can also have their pelvic floor as the weakest link, basically. I like this if we're looking at connections to the body. I particularly like the connection between the pelvic floor and the feet. And you can see a lot more of this when people are barefoot, which of course people are not barefoot at Wild Strong because we're outside running on trees and stuff. But foot contact on the ground can affect everything up the chain, including pelvic alignment. And foot stability supports core stability. Now, you're not going to see a lot when people have their shoes on, but you will notice things like people rolling onto the side of their feet, coming back on the heels, the toes coming off the ground. So, if you want to offer some playful movement suggestions, some experiences, and just some movement play, you might cue a tripod foot in the shoe. This is the base of the pinky, the base of the big toe, and the center of the heel. That's kind of like how we help generate those ground reaction forces. And it's a 50-50 kind of division. So through the front of the foot, 50% of the weight on the one side of the foot, 50% of the weight on the other, and through the medial part, 50% of the top, 50% at the bottom. And it can be interesting to invite people to just lightly ground their big toe if you see feet popping up. And that is interesting because we have what's called the deep front line, which is a fascial line. If you're familiar with Thomas Meyer's anatomy trains, the deep front line actually attaches at the front of the toe and it goes up through the legs, through the pelvic floor, and actually kind of ends at the base of the neck, goes up into the tongue. But it does help with that postural alignment and core stability. So looking at connections throughout the body, we can go all the way down to the feet. Again, looking at how it's part of the whole, this is just to kind of give you a lens about how everything's connected. Very often you'll see imbalances that can put stress on the pelvic floor. You'll see these in group fitness classes. This is not differences in anthropometry. So this is, we know that people have different femur links or torso links are going to produce different looking movement patterns, or if you're using different instruments, you're going to have to organize the body around them differently. That's not what this is. This is a little bit different. And group fitness classes, you'll see it. Do you address it? Maybe, maybe not. But you'll see things like people hip shifting. So maybe as they're squatting down and they come up, they shift to one side more than the other, which indicates that side is stronger. Maybe you'll very often see what's called the Trendelenburg sign, which is maybe in a forward lunge. You'll see maybe the opposite pelvis dropping down, rotating in. Maybe the knee comes in. Maybe they sort of twist the torso to the other side to compensate for that. And these things are interesting to see just because it potentially is putting more load through the pelvic floor and they're having to stabilize a little bit differently. And those are always interesting to address just as movement exploration, not that it's wrong. There's no wrong movement, but it's an opportunity to say, oh, how does it feel? How does it feel different if you do it this way or if you do it that way? And very often people say it feels harder, probably because it's activating different muscles. You just, oh, okay, feels harder. It doesn't mean you have to do it that way. It's just inviting you to play with some movement experiences. Sometimes they'll say it hurts, and then all right, well, that's interesting information. It's not because of a muscular imbalance. It's because it's a pain avoidance strategy, which is useful information for both of you. But you'll see some of these things in group fitness classes. And it's not imperative that you address them, but if you do, I think it's just interesting to address it from a lens of movement exploration. So signs it's too hard in a group fitness class. I think these are the really useful things to bring to your clients. If you notice leaking, if you feel a heaviness, dragging sensation, any kind of lower back pain, any kind of doming in the abdomen, that's your sign this was too much for right now. So it's important to push yourself, but listen to your weakest link. Here are your coaching levers. your movement strategies. And we'll go through these pretty quickly. Consider the time of day, as I mentioned before. If you have an evening class, just keep in mind um, pelvic floor may be tired. We've talked a little bit about posture and that core canister. I think that comes into play a little bit more with overhead movements, and we'll look at those in a minute. Body position and lever length, foot and leg placement. You can read through these. We'll go through them now. First is body position. So we talked earlier about how pelvic floor can be activated a little bit more easily in certain positions, and that has to do a lot with gravity and load and stabilization. So you can always think about perhaps if things like a kettlebell swing or a deadlift are too much, that's a hip hinge. You could bring that down to the ground and do glute bridges. Quadruped movements are really good. This is the bird dog. I throw these into our warm-ups a lot for activations, and it can tell you a lot about how somebody's organizing and their core strength. They can be regressed with one limb. Incline positions and shortened levers. So push-ups, planks, these are all very core heavy. There's potentially a lot of intra-abdominal pressure. So think about shortening your levers, go down to your knees or go onto an incline. Or is it something they could do seated so that the pelvic floor has a little bit more support? So changing the body position is always a good first move. Foot and leg placement. This graphic here is where there's going to potentially be a lot of demand on the pelvic floor because we're sort of at in ranges and that's a hard place to actually activate your pelvic floor. If you knew what you were doing and you could feel it, it's still pretty tough to do there. So you might want to think about things like sumo deadlifts, sumo squats, Cossack lunges, Cossack squats, potentially having some options for that, maybe with a narrower stance. Overhead press sometimes is a little bit easier to tolerate for pelvic floor with a staggered stance or seated. And keeping in mind that single leg or asymmetrical stances challenge pelvic stability a little bit more. So having some options there if that is potentially going to be too much. I think this is probably one of the most powerful strategies, but it's tough to use in a group fitness class, and that's just slowing it down. If you've got an AMRAP or a rounds for time or people waiting in any kind of a queue for equipment, it can be really hard to slow it down. But giving people a slower tempo allows them to really tune into what's happening with the pelvic floor. It reduces the momentum and any intra-abdominal pressure spikes that might be happening. And it just gives them time to respond. So it may be things like kettlebell swings are swapped with deadlifts and maybe step ups instead of any kind of jumps, and burpees may be replaced with inchworms, just things that let them slow down and less dynamic movement. Range of motion. So less range of motion in squats and lunges can be really useful because the deeper you go, the more intra-abdominal pressure you potentially are creating. So giving people these options, they may not realize that if they don't go as low, it might feel a little bit different. So just kind of making these things very explicit so they have room to play. You can combine this with slower tempo to give them a lot more control. Impact is something that often creates a lot of symptoms, and we would see that with jumping, running, vaulting, any kind of explosive movement. And impact isn't bad, but there are different strategies to titrate that impact and to progress it. And this is a hard one because a lot of people are very on to knowing that they need impact for bone density, but how do we regress and progress impact? There are specific protocols out there depending on T-scores and depending on pelvic floor function. And if you're interested in those, I'm happy to share what's there. But it's kind of basically finding where do we not experience symptoms. And I think talking very openly with people about this and talking about what symptoms they might experience. For example, you may experience leaking with this. If so, that's your cue. This is too much. Or if it's prolapse symptoms, those may not happen right away. You may not notice this until later tonight. You may not notice this until tomorrow morning. Even if you don't notice it until tomorrow morning, that's still your sign that this was a little bit too much. Just to keep these things in mind so people have it on their radar so that they can then know how to adjust their workout as they need to. Running. So we do some sprinting sometimes Tuesday evenings in Pangbourne. Sometimes we do a little bit of jogging. I'm currently finishing my certification as a running coach with England Athletics, and one of the holistic core restore programs I offer is a running program, getting people back to running. So I really like talking about this. Quick takeaways on running. Let's look quickly at these two. I just want to say no pelvic floors were harmed in the making of these photos, but let's look at the differences here. So on the left, if we're already looking at core canister, you can see a very different posture on the left. I'm a little bit more hunched over. So a nice thing to think about when you're running is having a nice helium balloon pulling you up nice and tall. You can see a definite difference on the right, whether that core canister is just a little bit, well, it's much better aligned, which is going to help breathing mechanics, which is going to help that intra-abdominal pressure. You'll see this happen a lot when people go uphill. They tend to kind of hunch over at the waist. We want that lean forward to happen from the ankles because we want to keep that core canister there. The big one I want to draw your attention to is on the left, you see a heel strike, and that leg is much further out in front, and that's going to put a lot more impact to the pelvic floor. Whereas here on the right, you'll see when that foot comes down, it's under my hip. And as opposed to a heel strike, that's more of a forefoot strike. You'll also see things happening with my arms, which I won't go into too much here, but I think the main takeaways here are try, especially if you're sprinting, forefoot strike, foot under the hips. How do you get people to do that? A lot of it happens with a faster cadence. How do you get people to do that? A lot of that happens with arm drive. So the faster you get your arms to go, usually the faster your legs will go. And very often the faster your legs go, the better a lot of these biomechanics start to come. So there's lots of drills you can, if you really want to get into running, there's lots of drills you can kind of play with to get this kind of technique going. But this can be hugely helpful for people who have pelvic floor symptoms and want to run. If you do any running in your classes and you have any inclines or declines around you, running uphill is a really good place to start. And that's because there's less aerial time of that leg in the air. There's less time, so there's a little bit less impact as you're going. Downhill running, especially downhill running with poor downhill technique, and downhill technique can be really tricky, can be especially tough on the pelvic floor. So maybe a run uphill and a walk back would be really good. Just quickly, if you're pushing anything uphill, like a sled or a buggy or something, that totally changes the dynamics and potentially makes everything much harder. And then you're going to want to look at how people are controlling that intra-abdominal pressure differently. But uphill is generally a pretty good place to start. Load and load positioning. So more load equals more pressure. And so basically have a variety of weights available. I have been that person in the group fitness class where the lightest weight they had was just too much for me. It was like 6 kg. It wasn't my pelvic floor at the time. It was my shoulder, and I was postpartum and just had a baby, but I was like, oh, I can't do this. It's like, it wasn't very heavy, but I couldn't do it. So have a variety of weights available because heavy is subjective. What is really heavy to one person may not feel very heavy to you. And then where the load is placed also matters for what kind of pressure it might put on the pelvic floor. So we might want to go with lighter load, but then we might also want to think about where we're carrying that load. This is for carries. I've just kind of created this to look at what is potentially easy for the pelvic floor when you're carrying something, but also keep in mind if it's a dynamic movement, like instead of an overhead waiter's carry, if we're looking at a push press, that's going to create a lot more intra-abdominal pressure and be harder than a carry. So potentially the easiest is when you have an equal load on both sides as a farmer's carry. Suitcase carry is going to be a little bit harder because you've got some, anti-rotational stuff happening through the core. Got goblet holds, single front racks, double front racks. It gets harder. A lot of this anterior loading can put pressure down on the pelvic floor. This is just kind of to think about, where are we carrying the load. Overhead carries can be made easier by making the lever shorter, so we're just bring it down for a front rack. And again, thinking about overhead presses, perhaps if it's creating problems with the pelvic floor, can it be done seated? And we'll go back to heavy lifting. Heavy lifting, like I said, heavy is subjective. And a lot of times when we think about heavy lifting, I think we think about kettlebells and barbells and things like that. But in Wild Strong, we're using a lot of like tires and sandbags, and that stuff can be pretty heavy. I struggled for a long time with these tractor tire flips. And the heavy lifting protocol definitely helps me with that. So the pelvic floor heavy lifting protocol, we'll look at that quickly. This is for you. This is a coach's lens. What's happening? We might cue it a little bit differently in a group fitness class, but just so you have a full understanding of where we're coming from. Starts with setting the base, so feet grounded in that tripod stance, maybe a little bit of a corkscrew out to create some tension through the hips and glutes. A big breath in, breathing down, so we're pressurizing that canister. That helps to support the spine. And then close the holes, which is basically activate the pelvic floor. And then brace, so little layer of brace on top of that if somebody's going to punch you in the stomach. And then blow before you go. This is the exhale on exertion. I think this is the main takeaway for this evening. Blow before you go, exhale on exertion, and start that lift as you are blowing out rather than holding your breath. And that should be a nice even blow. It's not really a, because that's going to potentially create some pressure too. It's a nice even exhale as you're going. Now, we've already talked about how that pelvic floor activation can be a little bit tricky. And if you're working with someone one-to-one, you can kind of see if they're getting it. You can work with them on it. In a group fitness class, you probably want to just simplify it a little bit. Ground the feet, take a big breath in, exhale as you come up. Probably sufficient. Everybody gets the cue, but those who need it or don't need it can just take it as they do. Another important concept that I came across, this is by a pelvic health physio named Anthony Lowe. He talks about training to the fences with heavy lifting. So with leaking and stress incontinence, this is often managed well with breath and brace strategies and gradual load progression. Prolapse can be a little bit different because there's actual pelvic tissues involved. And sometimes with heavy lifting, symptoms can flare. And that's when you know you've gone over your fence. Basically, train to the fence is train to what you know you can do without creating symptoms. And if you have created any symptoms, that's when you know, okay, we've gone too far. We need to regress it. It doesn't mean you'll never get there. It just means don't continually push yourself past your fence just because you can. Just because you can doesn't mean you should. So we want to be really mindful of training to these fences, but not beyond them. And this is a concept I often share with people. If they say they are if they've experienced any symptoms afterwards, it's okay. Well, we need to really regress whatever it was that you felt caused the symptoms. And a lot of that also is go a little bit less than what you feel like you need to as well, so that perhaps you don't find these fences by accident. So these are some exercises for you to have on your radar. These kind of exercises are things that are going to potentially spike intra-abdominal pressure, and it would be nice for you to offer some alternatives. Anything that's explosive and dynamic. So burpees, I often give an option for inchworms. Kettlebell swings, I will often offer deadlifts. A snatch is also a hip hinge movement primarily, so perhaps a deadlift with that. Any kind of jumping and plyometrics, so skipping, vertical or broad jumps, vaulting, some kind of regression there. Maybe some heel drops if they still want to play with impact, to see if the heel drops are okay. If the heel drops are still creating symptoms, then maybe we just want to go with some marching. Running, especially if you're running fast, especially sprints, and especially if you're going downhill. Any kind of demanding core work, so hollow body holds, crunches, planks, full push-ups, and stuff with both like Russian twists and things with both feet off the ground. So pull-ups, maybe even some of the eccentric, the slow lower down commandos potentially could create a lot of intra-abdominal pressure. So just having some regressions ready. So maybe instead of hollow body holds, maybe we're doing some baby rocks. Maybe instead of full planks, maybe we're on our knees. Full push-ups, let's do incline push-ups. Maybe we have one foot on the ground just to give us a little bit more support. Overhead presses and loaded carries, especially if people are holding their breath. Heavy lifting like goblet squats, tire flips, sandbags, and anything with the legs very, very far apart. And any lift with poor breathing coordination. So we want to look at exhaling on the hard part. For coaches, using that knack before you do any kind of voice projection can be really useful. I used to wonder why I would always have these pelvic floor flare-ups during half term and summer holidays. And it's not because I yell at my kids a whole lot, but they are loud, and I found myself trying to talk over them. And that's where, I kind of started to realize actually voice projection, if you are not consciously doing some pressure management, can put a lot of pressure down on your own pelvic floor. So here the trick would be to use the knack, that pelvic floor activation, if you feel you can do it, and hold it throughout your projection. Let's talk quickly about scope of practice. You are within scope when you talk about the pelvic floor, when you notice symptoms, when you offer lots of variations, and when you refer out. You're not expected to diagnose or fix anything. And I think it's important to talk about seeing a pelvic health physio in the same way you would talk about seeing somebody for your knee or your shoulder problem. It's just something that they have specialty in and are able to help. During a session, if it's kind of nice to have a bit of a traffic light system. Obviously, if there's no symptoms before or after exercise, you're good to go. Yellow light, amber light would be, okay, we need to modify. So if we have any symptoms, but they improve with change, when they improve with modification, or they only happen with really high intensity stuff, and we know how to back off that high intensity, that's all right. Red light, stop right away. Very severe symptoms, any pain. Client seems to be in distress. Client wants to stop, obviously stop and have them see somebody. Longer term, we're looking at referring to a pelvic health physio if anything's there for maybe over 6 weeks, if we have more than one symptom, if they get worse over time, if we're giving cues and modifications and it just doesn't seem to be progressively getting any better, then it's really a good idea for them to see a specialist. And when we're talking about seeing somebody, it can be helpful for them to understand exactly why somebody can help them, a physio can help them. A physio can do those internal checks. They can do an internal check and see, is this person actually activating their pelvic floor correctly? Do they have any prolapse? What kind? Where? What's the grade? They can perhaps advise on pessaries, which are inserted into the vagina and give the pelvic floor more support. They can also look at maybe manual release for very tight pelvic floors. They can give you very specific prescriptions about what's going on. Maybe it's a coordination issue with different muscles. Maybe something else is a little bit overactive. So they can definitely give you a lot more information and more specified guidelines on exercise. So I've always encouraged people to see a pelvic health physio if there's any question about that at all. So I've flown through that pretty quickly. I just want to end by reiterating that movement is part of the solution and not the problem. There's always some kind of option, some kind of modification that could be given. And hopefully these have given you some ideas for things that can be modified, how they should be modified, different options you can offer so that you can more confidently talk to clients about pelvic floor challenges that they have. So you don't have to be an expert. You just need to be able to help your clients continue to stay strong and active without shame or fear. Does anybody have any specific questions as we flew through that?
Thank you, Brett. Sorry, I've got loads of shouting and vomiting children in the background. Thank you very much, Brett. I had a question about, I hadn't really read much about the connection between feet and pelvic floor. Have you got any studies that you could direct us towards?
I'll be happy to post some. Yep, I can post some of those in the circle group.
Cool, thank you very much for that. Does anybody else have any questions? I know there was a lot in there, and you'll receive the slides and the recording afterwards, but if you've got any questions, do put them in the chat or just unmute yourselves. There aren't that many of us on the call this evening, so. I have got one more question actually, Brett.
Okay.
When I had loads of pelvic floor issues after my second, and it took me a really long time to find a good physio. I mean, you know, there are physios and there are physios, and I went through about 4 pelvic floor physios, pelvic health physios, until I found one that I thought was really good. I wondered if you had any tips on identifying a good physio rather than spending literally hundreds of pounds.
Yeah,
cycling through physios.
that's a really good question. Because I've had very much of a similar experience where I, you know, saw somebody privately and then I waited for the NHS physio and then I finally kind of found somebody I thought, yes, um, this person I think seems to have nailed right on the head what's happening and has been helpful. I think if finding a good physio is down to referrals, obviously that's where you'd start. If you have any issues yourself, go see some people, see what they have to say. Of course, then you are kind of going down that rabbit hole of how much money do I spend before I decide whether or not somebody is good and knows what they're doing. I think looking for just things beyond general advice, if all they're doing is saying here's the squeezy app, go do a bunch of pelvic floor contractions, it might be interesting to ask, okay, why? Can you tell me exactly what's going on? How is this going to help me? Do I have low tone, or is just asking questions, asking a lot of questions and listening to the answers perhaps. But I honestly have to say I don't really have the greatest answer to that because it can be difficult. If anyone's in my area and wants a referral, I do have somebody that I refer to here, but it has taken a while to find them.
Okay, well, thank you very much. If anyone's got any questions afterwards, Brett, have you got a slide with your email address on it?
Yes. Yep. Feel free to get in touch. If you have any questions or want any more information on any part of that, went through it pretty quickly. I hope it made sense. Hope it was useful.
Yeah, that was really useful. Thank you very much. All right, guys, we'll be sharing the recording in the next few days and a copy of the slides as well. All right, thanks for joining. Thank you very, very much, Brett.
Thanks. Have a good evening.